So I'll be talking on hypertension and stroke. As I was saying, hypertension is the first among the modifiable cardiovascular risk factors. It accounts for more than 10 million deaths and 218 million attributable disability adjusted life years worldwide. And it's the most prevalent risk factor for stroke. And that is based on data from several studies that reported as the key factor. We know that brain is a major end organ target of chronic hypertension that leads to an increased risk of stroke and dementia. And it has been shown hypertension is strongly, independently, and linearly associated with the risk of stroke. And as we know, stroke is the primary cause of disability and vascular death worldwide, and including Asia. If you consider statistically, it's the second most common cause of mortality and the third most common cause of disability. But there are three main types of stroke: ischemic, which can be full stroke or TIA, and the intracerebral hemorrhage and subarachnoid hemorrhage. In US, the proportion of ischemic strokes or intracerebral hemorrhage or subarachnoid hemorrhage is around 87%, 10%, and 3% respectively. And we can consider that worldwide, more or less, that is the usual figure. In Europe, more than 1 million people have a stroke every year. In 2025, the figure is estimated to be 1.5 million because of the aging population. 70% of the stroke incidents and 87% of stroke-related deaths happen in the low and lower middle-income countries. Also, the death rate is significantly higher in developing countries like ours compared with the developed countries. Professor Badul et al. Have shown in Bangladesh the prevalence of stroke is around 11 per 1,000 population. And whenever we consider stroke, we have to know something about the cerebral autoregulation of blood pressure. Cerebral autoregulation is the mechanism by which cerebral blood flow remains constant across a wide range of cerebral perfusion pressure that maintains a constant cerebral blood flow around 50 ml per 100 gram per minute. This is achieved by reflex vasoconstriction or vasodilation as is needed in the cerebral arterioles in response to changes in the perfusion pressure. And the blood flow, cerebral blood flow, is determined by the cerebral perfusion pressure and cerebral vascular resistance. And that resistance is governed by the arterial diameter. So the brain can maintain essentially a constant blood flow between a mean arterial pressure of 50 to 60 or even as high as 150 to 160 millimeter of mercury. That's the beauty of it. Look at this. If there is low pressure, then there is arterial dilatation so that cerebral blood flow is maintained. If there is high pressure, there is vasoconstriction so that too much blood is not going in there. In chronically hypertensive patient, the autoregulation curve is shifted to the right as a result of elevated mean arterial pressure. Hey, look at this one. The middle one is normal. In a chronically hypotensive patient, it is shifted to the left. In a hypertensive patient, it is shifted to the right. So, as a whole, look at the plateau in the middle to maintain the constant blood flow in a different degree of blood pressure variation. And the second point we should remember is what in ischemic penumbra. Tissue with the lowest cerebral blood flow would be irreversibly damaged and constitutes the core of the infarct in a stroke patient. The regions surrounding the core, the penumbra, are ischemic and dysfunctional, but potentially salvageable if we do the timely reperfusion. This hypothesis also suggests that if we reduce the BP acutely in the setting of acute ischemic stroke, it may worsen the condition because of the hypoperfusion of the penumbra and hasted extension of the infarct. In the ischemic penumbra, tissue perfusion follows perfusion pressure. Any fall in blood pressure may precipitate ischemia, while an increase in blood pressure may cause edema and hemorrhagic transformation. So, what's the role? People with hypertension are 4 times more likely to suffer from stroke if we compare them those without hypertension. Higher the BP, higher the risk of stroke. 10 millimeter increase in systolic blood pressure increases the stroke risk by 38%. Lower BP reduces the stroke as compared to mild hypertension. And hypertension has been identified as a risk factor in 66% patients with first ever ischemic stroke, who have either self-reported history of hypertension or admission BP of more than 160/90. And how does that happen? Hypertension induces oxidative strain, there is baroreflex dysfunction, there is inflammation, there is cerebrovascular morphological alteration as well as functional alteration. All this can lead to stroke. And high blood pressure can cause blood clots in the brain, damage the tiny blood vessel deep inside the brain, the penetrating vessels. And there is also bleeding in the brain that can be very frank or very minute. So there is ischemic stroke, or there can be small vessel disease or hemorrhagic stroke. And the ischemic stroke, there could be clot or there could be embolic. In the hemorrhagic stroke, there could be burst aneurysm or the torn artery causing intracerebral hemorrhage or subarachnoid hemorrhage. And in case of ischemic stroke, in all stroke subtypes, hypertension is the commonest denominator, the commonest risk factor. And is strongly associated with small artery occlusion and lacunar infarct. Lacunar infarct are essentially symptomless, but they indicate that the patient is at risk of major stroke or hemorrhagic stroke. Hypertensive patients have more cerebral white matter lesion on MRI. Presence of this finding predict a later occurrence of ischemic stroke. And the artery sclerosis of penetrating blood vessels is involved in the pathogenesis of white matter lesions that can lead to multi-infarct dementia as well. And when we consider the hemorrhagic stroke, hypertension alone or in combination with other risk factors accounts for 80% of the intracerebral hemorrhage changes. The odds ratio for developing intracerebral hemorrhage in patients with hypertension is about 3.7 if we compare them with the non-hypertensive patient. The risk of developing intracerebral hemorrhage increases with the increasing severity of hypertension. The relative risk is 2.2 for high normal BP, 5.3 for stage 1 hypertension, 10.4 stage 2 hypertension, and as high as 33 for severe hypertension. And in case of acute intracerebral hemorrhage, the hematoma expansion is more common in hypertensive intracerebral hemorrhage as compared to those who have intracerebral hemorrhage due to cerebral amyloid angiopathy, 45% versus 19%. The neurological deterioration is more common in those with hematoma expansion. Cerebral edema, perihematomal edema are also more in patients with higher BP. And higher BPs also lead to higher death rates. What about the diastolic BP? If we component that, we have considered hypertension as a whole. What about the hypertensive patient diastolic component and the systolic component? One study, the Eastern Stroke and Coronary Heart Disease Collective Research Group, they found diastolic BP, very high diastolic BP, had 13 times risk if the BP is 110 mmHg. If we compare them with those with less than 79 mmHg. But as a whole, systolic BP was more strongly correlated with 12-year risk of stroke mortality than diastolic BP in Framingham Heart Study. In a prospective population-based Copenhagen City Heart Study, they also reported systolic BP is a better predictor of a stroke than diastolic BP. And after a 10 millimeter decrease in systolic BP, it was associated with a 41% lower risk of stroke in Asia and 30% in Australia. So, as a whole, in elderly patients, those who are the more prone to developing stroke, systolic blood pressure is a better predictor of a stroke than is diastolic pressure. And whenever we consider an acute ischemic stroke, we have known that if you reduce the BP2 mass, there will be expansion of the ischemic area. And if we do not reduce it adequately, there may be hemorrhagic transformation. So the management of blood pressure is always complex in a stroke patient. And if we consider in a long-term prevention, if you reduce the pressure for primary prevention, secondary prevention, the reduction of blood pressure perhaps is the most important thing in reducing the risk of stroke in future. In a patient who have a stroke, an acute hypertensive response can be observed in patients with acute ischemic stroke. It is usually self-limiting, and the BP spontaneously falls over the week after the onset of stroke. But since the acute hypertensive response to stroke is known to be an independent predictor of poor outcome, it's necessary to maintain optimal BP. The key term is optimal BP. And the BP control recommendations vary depending on the comorbid conditions, according to the AHAS guidelines. Early treatment is indicated in patients with severe acute comorbidity. For example, if the patient have an acute coronary event, or acute heart failure, or acute aortic dissection, or if the patient develop intracranial hemorrhage following fibrinolysis, or there is hypertensive emergency, or preeclampsia or eclampsia. This is class 1 evidence. But an excessive decrease in BP can exacerbate cerebral infarction. BP management in this situation should be individualized. However, it can be generally considered safe and reasonable to lower the BP by 15% from baseline. In patients with BP less than 220 over 120 millimeter mercury, initiating or reinitiating treatment of hypertension within the initial 40 to 72 hours after acute ischemic stroke may be safe, but not effective in preventing death or dependency. So it's a class 3, no benefit. We can wait till up to 72 hours. Again, in a patient with BP more than 140/90, who have become neurologically stable after 72 hours, starting or restarting therapy during hospitalization. During hospitalization, after the initial period, we can start it. Cossacks and China hypertensive trial and acute ischemic stroke have shown them. Look at this. The guideline says, so in case of hypertensive emergency, you have to lower BP by at least 15%. If you have to give RTPA, fibrinolysis, we have to reduce the pressure less than 185 over 110 and keep it below that afterwards, after the RTPA is given. And if the patient have hemorrhagic stroke, if the patient is not going to receive any IV alteplase or endovascular therapy, or do not have any comorbid condition, if the patient has very severe BP, we can reduce it by 15%, but no more. So we should remember that aggressive lowering of blood pressure may lower cerebral perfusion pressure and thereby aggravating brain ischemia. And again, on the other hand, very high BP can worsen cerebral edema, and that can also result in poor outcome. So extreme hypertension can also lead to encephalopathy or cardiac complications or renal insufficiency. So we are seeing that case fatality in acute ischemic stroke follows the U-shaped curve with regards BP. Higher death risk come at too low or too high BP. The best outcomes are observed at systemic BP between 140 to 180 millimeter mercury. So antihypertensive medications are better to be withheld as long as systolic BP is 220 millimeter mercury or lower, diastolic BP is 150 millimeter mercury or lower in initial 48 to 72 hours. But in a stroke patient who is undergoing IV thrombolysis with alteplase or tenecteplase, antihypertensive drugs, if the systolic BP is not that high, is 185 millimeter mercury or lower, or diastolic BP is less than 110 millimeter mercury, we should not be using any antihypertensive. But if it is more than that, we should lower it, then start the IV thrombolysis. We can use levodopa or nicardipine. Levodopa is widely available in our country, but however, unfortunately, nicardipine is not. These two drugs are very important in the regard that, though perhaps we are very much used as cardiologists, we are used to using IV nitrate or nitroprusside to lower BP in other hypertensive conditions. But these two drugs increases the intracranial pressure, so they should not be used here. The two safest drugs are perhaps the levodopa and nicardipine. But what about those conditions when the patient has a stroke and the blood pressure is low? We know that The hypertension in the first 24 hours may be beneficial as it improves the cerebral perfusion pressure. Some small studies have used phenylephrine or norepinephrine in the first 24 hours to keep the BP high normal or mildly high. And they show improvement in ischemic deficits, including aphasia. Improved perfusion was also noted in MR perfusion studies. But this treatment, though it appears promising, further larger trials are not yet there, and so they are not included in the guidelines. So we have to remember that if the BP is very low, we may sometimes try to increase the BP to improve the outcome. What about hemorrhagic stroke? That could be intracerebral or subarachnoid. The most important cause is hypertension, but other causes are bleeding diathesis or amyloid angiopathy, drug misuse, or vascular malformations. Hemorrhagic strokes are categorized either into intracerebral hemorrhage or subarachnoid hemorrhage. I see it accounting for 10% to 20% of all strokes. Subarachnoid hemorrhage is about 3 to 5%. Hemorrhagic stroke occurs less frequently than ischemic stroke, but the morbidity and mortality are still considerably high. And since these patients often deteriorate rapidly within a few hours after onset, appropriate management in the acute stage is very, very important. We have to consider these issues: hypertension or anticoagulant reversal, antiplatelet reversal, hemostasis when there is hemorrhagic stroke. The primary medical treatment for acute spontaneous intracerebral hemorrhage is BP management, in which the goals are to reduce hematoma expansion and perihematomal edema, improve the functional outcome, and reduce the mortality. The BP should be controlled to balance the risk of rebleeding while still maintaining the cerebral perfusion pressure. So what the guidelines say? Systolic pressure between 150 to 220 millimeter mercury. We have to lower the BP acutely to a target of 140 millimeter mercury. And the target is to maintain it between 130 to 150. If you lower it too much, that will again be deteriorate the condition and may be very harmful. Initiating the BP lowering treatment within 2 hours of the intracerebral hemorrhage onset and reaching the target within 1 hour can be beneficial. But if there is large or severe intracerebral hemorrhage or those requiring surgical decompression, we are not yet sure the safety and efficacy of intensive BP lowering. Subarachnoid hemorrhage that accounts for 2% to 70% of all strokes, but for a larger proportion of morbidity and mortality from stroke because they involve younger patients and have high mortality. The most important cause is a ruptured intracranial aneurysm, which accounts for 85% of the cases. It affects 6 in 100,000 individuals each year in developed countries. Rebleeding before aneurysm repair may be the most preventable serious complication of subarachnoid hemorrhage. The factors associated with rebleeding are temporal proximity to the first hemorrhage, higher blood pressure, worse neurological grade, intraventricular or intracerebral hemorrhage, larger aneurysm. Prevention of rebleeding may be achieved by treating acute hypertension, repairing the aneurysm as soon as possible, and administering antifibrillatory drugs as needed. So, what the guidelines say? The American Heart Association guideline recommended for patients with intracerebral hemorrhage presenting with systolic BP 150 to 220, we have to lower the BP acutely to 140 millimeter mercury. That's safe. But systolic BP, if there is raised intracranial pressure, we have to keep the cerebral perfusion pressure between 61 to 80 millimeter mercury. And we should not be using drugs that have prolonged action or that can lead to precipitous decline in BP. The previous tradition of using sublingual nifedipine henceforth is very, very bad. In the acute phase of subarachnoid hemorrhage, there is some difference what to expect and what to do. The American Stroke Association recommends less than 160 millimeter mercury of systolic BP. The Neurocritical Care Society says less than 110 millimeter mercury of mean arterial pressure. I think the first one is better to useful to use for us. European Stroke Organization say that the intensive lowering systolic PP to less than 140 milliliter mercury within 6 hours of intracranial hemorrhage stroke onset is beneficial. We can use the thrombolysis, they will be talking. And what about the antiplatelet? In ischemic stroke, administration of aspirin is recommended within 24 to 48 hours. But those who are being treated with IV alteplase, it should be delayed until 24 hours later. And if the patient has minor stroke, treatment can be considered with dual antiplatelet for 3 weeks, began within 24 hours. Other antiplatelet that can be used are tiotropium, AP50 level class 2B evidence. Axicimab and ticagrelor should not be used. What about anticoagulation? And they should be used in very specific cases. For example, severe stenosis of an internal carotid artery if related to ischemic stroke, or an extracranial interluminal thrombus in the setting of acute ischemic stroke. We can use dabigatran or other direct thrombin inhibitors or factor Xa inhibitors. So that's the summary. For primary prophylaxis, if the patient who is diabetic or hypertensive, who is aged, who is likely to have a stroke, keeping the blood pressure less than 140/90 is useful. This is primary prophylaxis. But if the patient already have a stroke, we know, we already have told, we can start alteplase or endovascular therapy, and then we should keep the systolic BP less than 185 or diastolic BP less than 110. But if you're not using thrombolytic therapy, then we can keep reasonable to maintain the BP more than 160 at least, and around 185, 110 is reasonable for the initial 40 to 72 hours. For the hemorrhagic stroke, the target BP is systolic 140 milliliter of mercury. And for the secondary prophylaxis, again, less than 140/90 is acceptable, but in some cases it should be lowered less than 130/80. However, particularly in a patient with lacunar stroke, systolic BP 130/80 or less should be targeted. Look at this graph. If you have higher BP or if you have too low BP, either way, systolic blood pressure, there is a U-shaped curve. In the middle part, it's better. And diastolic BP, similarly, if you lower it too much, there is increased chance of stroke. If you keep it higher, chance of stroke is higher. Again, all death, similar pattern. So, madhyapantha uttam. Keep the pressure within a reasonable limit, that's better. Do not lower it too much, do not keep it higher. And never forget the lifestyle modification, including exercise, healthy diet, healthy weight, limiting the alcohol consumption, avoiding the tobacco, and reducing the stress, and of course, monitor blood pressure. My take-home message is that hypertension is perhaps the strongest risk factor of stroke, and one that can be controlled much more easily than many other factors. The prevalence of hypertension as well as stroke are rising day by day because of the aging population. High blood pressure reduction is one of the most important factors for reducing stroke morbidity and mortality. And the consistent blood pressure control is the key factor for any kind of stroke prevention. Thank you everybody. সবাইকে কার্তিকের শুভেচ্ছা।